Good afternoon, everyone. There are still some people coming in. I'm Dr. Ron Henning-Hockey, and I'm the Chief Medical Officer here. And I'd like to just do a little introduction and welcoming an introduction of Dr. Cady. And also to let you know that the bathrooms are this way. They're down at the end of the hall. Is there any other housekeeping things? Oh, books. And Dr. Cady's book, Paindemic, is back there. And that was really what I wanted to tell you, is that I know a little bit about Dr. Cady because I think we're on the same journey, honestly. I went through KU Medical School. Dr. Cady is an osteopath, and the osteopathic tradition, believe it or not, started here in Kansas. Dr. Andrew Stiles was here in Kansas, and then he started his college in Kirksville, Missouri, in terms of the osteopathic approach. And he, like Dr. Riordan and the Riordan approach, is looking at what are the real causes of chronic illness. He was involved in the Civil War, and many of you may not know, but there was a huge morphine epidemic after the Civil War because morphine could be bought without a prescription. And so a lot of people became addicted to morphine, and the patent medicine doctors, that was the beginning of patent medicine, was around right after the Civil War. And the American Medical Association began as an institution to control the inappropriate use of medicine because medicine had a very bad reputation. And it was only in 1950, when penicillin was introduced and the rise of antibiotics and the idea that you could take a pill to solve a disease became accepted. And now what we find is that we've gone too far. We've tried to take all diseases, all chronic illnesses, and find the pill for the depression or for the heart disease or whatever it is, the cholesterol problem. And I'm thinking what Dr. Cady's going to talk about, and part of what I like to do is read books, and her book is on my list. I have not read it, but I read a lot of books. I listen to a lot of books because honestly, in modern medicine, you're not going to get the story from your average doctor because most doctors are trained in a pharmaceutical model that is still in this one ill, one pill model. And frankly, to get through the day with the rising tide of chronic illness, we were taught, prescribe a pill, and then you can walk out of the room, prescribe a medicine. And so, but the type of medicine that's going to be the medicine of the future dealing with chronic illness is looking at all of the root causes, the real causes, discovering what they are, and then making changes in your life that help you gain more effective control over your health and well-being. You are going to be your most important caregiver in this new approach to medicine. So I'm thinking, am I wrong? Is that
spot on?
I think this is what Dr. Cady's going to be talking about. So please welcome Dr. Melissa Cady talking about the Paindemic here in the United States. Thank you.
Yeah. Thank you. And I heard word, was it Connie, you said that is it the World Peace Day or Gratitude Day? So I just want to be grateful for the fact that you're spending an hour or 30 minutes to an hour of your life with me just to hear my message. And obviously, Paindemic is just my message put on paper that I never in a million years thought I would write a book. It was the last thing, especially in medical school, you're just trying to survive. But in reality, just to give you a little background, I did 4 years of the osteopathic school training. I did a year of general surgery, a year of internal medicine, 3 years of anesthesiology, and 1 year of a pain medicine fellowship. So I'm board certified in anesthesiology, also in pain medicine. However, I became very disenchanted with the whole idea of these traditional pain clinics when I went for 2 days to just substitute right after my fellowship training, 2 days of subbing for a physician that's doing pain medicine, and I ended up having to do what he normally did, and that was over 50 prescriptions of opioids, which are the heavy painkillers that you hear of in the media. It's been a big buzzword lately, but I didn't want to have a part in that because I feel like that's just one tool. And just like you're saying, it's not just about one thing. And I went into the osteopathic school. I was accepted into an MD school as well. And what's interesting, the biggest reason is just I wanted to do DO school. It was all one application process in Texas, but it's because there was another tool. I was just curious to learn another tool, which just happened to be some manual diagnosing and treating with the hands. So, and I love the musculoskeletal system, so of course I just wanted to learn another tool, which I think is valuable whether you're a physician or medical professional or you're a patient. So having as many tools in your toolbox is probably the best thing we can do for the society and for your own health. So this is a reason I wrote Paindemic. This little short presentation is not that you want to go in quite as much detail. Of course, I'll do a little Q&A afterwards, but this is going to be more about the 10 myths about pain that I wanted to cover in this little presentation. So first of all, what is the Paindemic? I randomly came up with this name at a conference when someone said you should write a book. I don't know where it came from, it just dropped in my head, and it was perfect. I felt the rising tide of all the media coming around, the opioid overdoses that were going on, and I went ahead and just claimed it for myself. So that's why the title of the book's Paindemic. But what it really is, you can say it in all different ways, but the most basic is a complex epidemic or pandemic of chronic pain that persists despite the associated overuse of the opioids, the injections, the surgeries. You would think that if we had all these things to offer, that these things would get better. But in reality, it's just worse. And so that's why I call it kind of a playoff of pandemic. It's really a paindemic. So most of us have heard this stat. It's been out there since 2011. Over 100 million Americans with chronic pain. However, that is variable, depends if it's an intermittent, occasional pain, sometimes the burning constant, severely debilitating pain. We have all different variations of chronic pain. So the 10 myths is this little lecture I put together for your short lunch and learn. The first myth is that pain is always bad. Some people probably think this. And this is the definition of pain. Most of us don't want to have an unpleasant experience. We can all agree on that, I think. So it's usually not just a sensory. You feel maybe you stubbed your toe. That hurts. It's physical to you. You perceive it down here on your toe. But there can be emotional pain as well. So both of those things tie in together for the whole experience of your pain. And that's actually a definition that you can see there from that organization. So who wants a pain-free life? Sounds like a great way to live, I would think, or most people would think. But I want you to take a look at Stephen Pete here. Can you see him? I don't know if you can see a little abrasion on his forehead. He has a couple of mittens on. This particular gentleman I spoke to personally via email. He has a congenital insensitivity to pain. He has no ability to feel pain at all. Sounds great in some ways. Not so much if you're their parents. So in this case, you have to worry about them chewing off their fingers. Feels cool to them, doesn't hurt. The other thing is that when you hit your head against the wall, it feels cool too. Problem is you can get a bleed that can kill you. And the other thing you can't see is he almost bit off his tongue because it's the most accessible, fun thing you can play with in your mouth, and if it doesn't hurt, it feels kind of cool. The other thing about this gentleman is his brother also had a congenital insensitivity to pain. And the bad thing about growing up with this is that when you become a teenager and you're the cool guy and you can jump off a 2-story home, you end up doing it and you get hurt. And he became so disfigured and was so troubled by all of the problems he had because of that, that he committed suicide. So I like to bring extreme examples to kind of bring us back home to why pain is so important. I really think it's more of an alarm. Some people call it the harm alarm. It's really trying to tell you something's not quite right or in balance with your body. Now, some things can be an acute injury, something life-threatening. Sometimes it's just trying to give you hints that there's something you need to do differently to change your life. So I think of it as a gift. Some people that are in extreme, severe pain, day in, day out, month after month, year after year, it's really hard to see it as that. And in the system that we live in, as far as the medical system, it can be really frustrating when you don't get any progress or any improvement with your situation. Myth number 2, pain is well understood. I think you probably know the answer to this one. It's an invisible experience by the patient. It's very difficult to prove. Complex phenomenon in a complex body. I think as you go through life, you start realizing how miraculous the body is. Physicians are poorly taught on pain. If you look at different studies out there, anywhere from 4 to 9 hours, maybe, of actual pain studies in medical school. Just depends on the curriculum. I think that will change, maybe in the next 5 to 10 years, but it definitely needs improvement. The causes are poorly understood. If you notice, most of what we do in this society is we treat symptoms. So there's a lot of these treatments out there, and you really have to think in these terms that most of what's being done out there is to treat the symptoms. In some cases, it's okay to bridge the symptoms to allow healing, but if it's not healing or we're not dealing with the cause, that can cause problems and frustration. Same comment on the same issue. So if you don't understand the causes, then our treatments are not going to be probably directed appropriately. So we need to understand pain better. This is one I think everyone in society should know this, and it always baffles me how many people really don't know. Myth number 3 is MRIs reveal your pain source. So if you see an image, you go to the doctor, you have back pain, you see this image, you've never seen the inside of yourself before. It's pretty fascinating to see the inside. And you see these things and someone convincingly tells you, well, this disc is degenerated. Your back's falling apart. You look 80 years old and you're only 50. I mean, if you hear that, your brain is not going to feel so good about things. And it doesn't feel like you can change it. So when you see an image like that, just take a step back and listen to what they have to say. And I'll explain here why. There are limitations to this technology. So that image is actually someone laying on their back for one snapshot. But you don't really have the movie of the life of how that body moves, the physiology that's going on within the body. So you really don't get the full picture. It just gives you an idea of one quick snapshot. And so what happens, you see something's abnormal, you assume the pain is because of that, especially if it's in that vicinity. So I write in the book about the pain disconnect, my little play on word here. The disconnect between people's assumptions of what's going on in an image and the reality of their pain. So if you look at this, this is one of 3 that I have in the book, so you get a little sneak peek. But this is about disc degeneration. And if you look based on the years, you have 20s, 30s, 40s, 50s, 60s, and 70s. And if you look all the way, once you're 70 years old, 93% of you, these are people with no pain. They took a conglomeration of a whole bunch of studies, and I put this into a graph form for you so it wouldn't be so hard to read. But if you're looking at people that are in these studies with MRIs, one of them was a CT study as well, but put all those MRI and CT studies together, and you look at all the disc degeneration, and these are all people with no pain. 93% of people with no pain will have disc degeneration. That's one of my biggest message to people, not necessarily that percentage, but the fact is that there are abnormalities that are normally in your body because you're using your body throughout your life. You're not just laying like this all your life. Your body is, the bone is a living tissue. Everything is constantly regenerating, degenerating, changing in form and shape based on what you're doing with your body or not doing. So just remember that sometimes it could be relevant, but you have to look at the big picture of what your symptoms are and be a little wary if you don't have any urgent, emergent reasons, especially surgery, that you maybe get a second opinion if someone thinks that just because you have an image finding that that's the most relevant thing. It's hard for you sometimes as patients to understand how to differentiate that, but just know that there's abnormalities. Just like we see wrinkles and gray hair as we get older, but we don't sit there and call it degenerative hair disease. I put that in the book, but we don't sit there and try to treat it because we all are very familiar and comfortable with the fact that this is a normal part of aging. Bottom line, normal part of aging. We get degenerated, especially in the lower lumbar spine where we're constantly flexing in ways that maybe we shouldn't be doing all the time. We still want to function, but you need to be smart about how you move. So MRI abnormalities do not always explain the pain. It can explain some. Myth number 4, Your pain diagnosis always equals a reason for your pain. So what's that tell you? What's failed back surgery syndrome? That really doesn't give you, it tells you the surgery didn't work. I mean, that could be a misdiagnosis and be a simple asymmetry, a muscle asymmetry that led to some soft tissue, connective tissue problem and was never addressed. They went straight from primary care to a surgeon. They did an MRI, disc degeneration. Oh, it's your L5-S1 disc. Let's do surgery. And voila, your pain's still there after surgery, or worse. And they call it failed back surgery syndrome. A lot of times it's the fusions, the back fusions, they'll call these failed back surgery syndrome. Post-laminectomy syndrome, same kind of thing. They do laminectomies. They try to remove part of the laminas, part of the bone to kind of free up the space that where the spinal cord might be crowded, or maybe a disc is in the way. They need to take a little piece of disc, or they think they need to take it out. Low back pain. I just reiterated your symptom. That doesn't tell you anything. No understanding at all. So as a patient, you're given no information on how you can help yourself. You just have low back pain, and they'll be offering many times a lot of symptom-oriented treatments. So 3 things in the book that I emphasize are just some of the systems. I also want to mention, I call the body a brody, BR-ODY, because the brain and the body are really one interconnected. We still try to separate them out, and we're really just one big integrated system. I'm sure you would agree with that. And there's all these other little systems that are important too. So I emphasize 3 mainly because connective tissue, massage therapists, there's various other alternative or complementary medicine practitioners that I think have a better appreciation for this than physicians. I even have my own physicians scoff at some of the things that they just don't understand. So I don't blame them, because until you maybe go through chronic pain like I have, you don't really have that same personal experience. And you know you're not crazy because you know something helped. And some of the things you did for yourself too can actually help. The third thing is the nervous system. And there is an enormous amount of research. I can't even keep up with it. One person can't keep up with all research, period. And that's why it's hard for physicians to know everything anyway. There's just so much to learn about the body. Like I say to people, if we only came with that manual, we'd know it all.
Neuroplasticity, that whole thing.
Yes, that's coming up. In fact, for all of you that can see this, if you can take your finger and place it right between the gray and white box, try to divide. Do you see anything change? Colors? If you get it where you just put it right and close one eye, maybe. Anyway, it's supposed to change. Do you notice it?
Yeah, the white.
Yeah, so it looks all gray once you take that little,
Yeah.
It's really all gray. It's just the way that they played a trick on your brain. I was just trying to let you know how our brains can deceive us sometimes. So mentioning those 3 areas, connective tissue, biomechanics, the nervous system, if we don't even have a good appreciation for those things from our training in medical school, then how in the world are we supposed to help patients with potential other sources that we're not accustomed to diagnosing? If we don't have good diagnosis or ability to diagnose well what the problem is, then how are we supposed to give you the best treatment? So that's where some of the challenge is in the medical field, is trying to look at the other things. I mentioned a little later some of the other ideas. So it's a journey. You have to be patient, because sometimes it takes multiple providers, or going to a great Riordan clinic or integrative places where they have multiple people that can help you with various things. And we need to find a better pain understanding so we can help you better. Myth number 5 is all pain patients are crazy. So unfortunately, I hear this sometimes, and it really drives me crazy too. So let me just set up the scenario here for you. Pain is poorly understood. We've already discussed this. Physicians are poorly taught on pain. Treatments are not always addressing the cause, treating symptoms. The medications you get might have side effects. The injections and surgeries have risks and potentially additional pain. Multiple appointments with extended waiting room times. little time with the pain professional, maybe 5 minutes, maybe 15. Poorly treated pain can rev up your nervous system, make your pain worse. Pain patients just want pain relief. Many pain patients don't even feel heard, and many patients do not receive adequate education and options. So it's no wonder that most people feel like they're going crazy. I mean, you're not even being heard, things aren't being addressed. The way we're addressing it can cause other pain and make the pain worse. So I always try to take the side of trying to truly understand, and a lot of my colleagues do too, but there are sometimes people that just sometimes might think they're crazy, but there's a reason. They're hurting, they want relief, and you're not giving the resources of the education to help themselves at the very least, and then what you're doing may not really be resolving the original problem. So pain patients need to be heard, and pain patients just want the pain to go away is my last statement there. So myth number 6, pain pills fix pain. I think you know the answer to that one. It just turns down the volume, doesn't treat the cause, just treats the symptoms. You don't think as clearly. Some people think they do, but the funny thing is people on the outside might be able to tell that you're not thinking as clearly, but you think you're thinking just fine. It can slow down your bowel and your bladder, major constipation, emergency room visits for things like that, things that no one wants to talk about. It can worsen your sleep. People think it might help you sleep, but it actually can ruin the way your sleep rhythm is, and depresses your breathing, which is a serious issue. In this country, we have serious sleep apnea, and a lot of people that I've talked to do not actually wear their CPAP, so they're in a compromised state of having obstruction. So when they're laying down, especially flat on their back, and all these soft tissues want to collapse on itself, and then you add opioids or heavy painkillers, morphine, hydrocodone, all of those, then you can create a situation where people can die. And that's why you hear about the overdoses. Not all overdoses are just the opioid, though, usually combinations of things. So we knew in 1999 through 2010, there was a quadrupling of almost 4,000 deaths to over 16,000 deaths of overdose related to opioids. In 2012, 46 people a day dying related to opioid overdoses. And 259 million prescriptions were written by health professionals in general, enough for every adult to have a bottle of pills. So the problems is diversion. You may think that it's just going to go in your cabinet. Your little teenager or someone else might steal it from your cabinet. Maybe they'll go sell it on the street, sell it to a friend. Tolerance, you start building a tolerance. You need more and more of the medication, so the side effects can go up higher and higher. You get dependent on it. So even if you're not really addicted and craving it, even if you took that medicine away, your body is so used to that chemistry in your body that you take it away and then suddenly it goes into withdrawal, which you feel very, very sick. And addiction, of course, that's a potential. They thought it was less than 1% in the 1990s when they started bringing it back, and that's not quite so little. Obviously, the addiction potential is higher than 1%. And what's called opioid-induced hyperalgesia, that just means you take a strong painkiller and it actually can make you feel like you have more pain. So by taking away that painkiller, actually your pain could start going away. When these people start getting the opioids or painkillers at higher doses, it actually can make your pain worse. But you don't know who that person's going to be. At least at this point, we don't have a test for that. So it's called OIH, or opioid-induced hyperalgesia. So a lot of physicians don't know about that. There we go. Difficult to convince patients to take. It's like taking candy away from a kid sometimes. Once you give someone something and they know it helps maybe 15 to 20% with their pain, they will hold on to it like no tomorrow. Especially, the worst thing about that is if you don't do any other conservative options, then trying to get them to believe or see that something else can help them is really difficult because they've already convinced themselves this is the only thing that's going to help them. And by no fault of their own, they just want their pain to go away. But if no one else gave them other options beforehand, why would they get rid of the opioids and go to something else? So it's a difficult situation. So by not addressing the cause, we can actually worsen the pain problem. If there really is something going on and we just keep turning down the volume of our pain, and your alarm system, your harm alarm, is not allowed to pay attention to something not being right, then you're never going to address it. So it's easier to just kind of just take the pill and never address the issue. Not for everyone, but some. So it's a very slippery slope. Your opioids are not fixing anything. They're just helping your pain. It's just the symptom of another potentially acute problem. Most time it's some other chronic ailment we need to address. Myth number 7. You're going to love that one. Profit or greed never influences pain treatments. My colleagues are probably not like me for this. However, I would say most people are in this profession for a reason. They give up 10 plus years to do training and go into debt, and their heart is in it. But there are some people out there that because they're caught in a system that's broken, they have to do what it takes to survive. And in order for them to pay the overhead, in order for them to do what they need to do, the things that pay are not educating you. And that's what we really need in pain medicine. So there will be times where there might be just, this is what they've learned. They really do feel like it's helping you or could help you, but they didn't learn anything else to give you as well. So in order for them to keep surviving and actually have the practice of the few skills that maybe they learned, obviously there's money involved there. I'd have to say on the medical claims, that picture there is insurance companies have to make money. So there's only so much money to go around. So you might have to be a squeaky wheel if you want to get things approved, if you're going to go with the medical system, which all of us have been forced to in some capacity be part of. So this is not the pretty stuff to talk about, but it's become more of a transaction business instead of a relationship business. And I think when you deal with pain, you need to get to know the people that are having pain, because it's just not the image. It's what is your life? What does it consist of? What stresses do you have? What kind of anxieties? What kind of depression? All those things can impact pain too. It's not saying that's all just the head, but there are definitely things that are going to impact the behavior patterns that you have that may be leading themselves to maybe some problems with pain. So I always say seek patient advocates, not pocket advocates. That's kind of hard to tell people how to do that. But I think if you feel like someone is really trying to educate you and give you options and not give you only their option, and this is the only way or the highway, I think that's a pretty good rule of thumb. I have no problems getting second opinions from people. We are human, and we're physicians trained in a medical system that's gone a certain path, and I think that we all should collaborate. We should be collaborating with each other as physicians or medical professionals so that we can get the best care to patients, because you deserve that. So myth number 8 led me right into that. So not every diagnosis is correct. We all have different approaches. We have different perspectives. We can't forget that. Sometimes just need to get a different set of eyes. On a different day, maybe the same person, different day, they'll see something different. So worthwhile getting a couple of opinions. And I really believe that a lot of the integrative medicine really fits pain medicine really well. Because if you're to look at someone, let me give you an example. Anyone heard of anyone having cataracts before? Okay. How many of the people you know that had cataracts, they had a successful surgery and they can see now through their eye? Yeah. So the percentages of success for that surgery, really, really high, because we are actually able to know precisely what the issue is at hand. There's a cloudy lens. Maybe there's some preventative things we could do by diet and avoiding sun and all these other things. But when you go and you take the lens out and put a new lens in, it's a pretty definitive success. Pain is way more complex than that, and it's not as definitive of a pinpoint diagnosis. So if you have, say you just went in to say, I have decreased vision. I'm going to compare low back pain to decreased vision. Decreased vision. Oh, let's just go give you a cataract surgery. Well, you need to know you have a cataract first. You can't just say, there's decreased vision. You're not going to have great success with surgery if you just put everyone with decreased vision to get a cataract surgery. So we are really good in that particular area where cataract surgery is definitive. Low back pain, if I just say low back pain, everyone go get a discectomy, our success rates aren't great. Our diagnostic ability for low back pain is not like it is for like a decreased vision situation. So I use that example just to give you how complex it is. So back to the whole integrative medicine. In cataracts, I don't think you need integrative medicine per se to take care of the problem. I think you just go to an ophthalmologist and you go take care of it, and you're going to have pretty good success. But when you have pain and we're not quite sure where it's coming from, or our diagnosis is kind of difficult to lay out, then by integrating multiple skills, multiple people, multiple perspectives, you have a much higher chance of improving your pain. Just because there's some of these elements in different systems that I say, and I may not even know yet of other things, that they may be addressing and help you. So that's actually one of my big messages, is that there's a big reason why we should, I think this country's going there one day, that we'll have a better integrative setup. So if no red flags, you got to rule out any acute emergencies, then it's reasonable to get second opinions if it's an elective, pain type procedure. Myth number 9, physicians have all pain tools. I think this resounding topic that I keep talking about. We don't have all the answers, just one person. This is just some ideas of some people out there. I call them body assistants. They assist you in trying to help you figure out what's going on with your body. I don't like to just say body worker, because I want it to give the implication that is not them just doing things to you, but giving you the education so you can help yourself too. So I think most people here can do things to you or for you, but also can educate you to help yourself. And there's just a long list, and it can keep going on for a couple more slides. These are various techniques that can address the musculoskeletal, like connective tissue, the biomechanics, the nervous system. All of these are integrated. Our whole body's integrated. So everything that they do, at some point, whether they're directly saying it or not, are probably impacting one of those systems. And then brain assistance. If you can't figure out what's wrong with your pain and it's getting very bad, if you can have someone help you deal with pain, because it can get you depressed, it can make you anxious, and both of those things can rev up your nervous system. So just going to get someone to help you with your mind while you're contending with pain does not make you crazy. It's just helping you cope with it while you're still on your journey to find ways to decrease your pain in other ways, if you can find the solution. Myth number 10, education has little impact on pain. Obviously, you know the answer to that, because I'm sitting here educating. So perception is important. If I told you your back's falling apart and you get the impression it looks like this, I took a model and just ripped it apart, you probably would not feel good about your health or feel good about your body, and you probably would get more rigid in what you do, because you're probably worried about hurting it, and that hurt means bad. Your back is pretty amazingly strong. It would take some strong forces externally to actually damage you or hurt you. So the perception that you get from the medical professional that talks to you is very important. So what they say is impacting your nervous system, impacting your brain, and impacting your function and your behavior. So I find it very important on how someone talks to you. I'll tell you a story if we have time here in a few minutes. So this is just a quick study out of Australia in 2004. They did some education from a physical therapist, about 3.5 hours apart. And look at the difference in their leg raising and bending of their back just from the education. On telling them not to catastrophize, which is a big word we didn't go into, but if you make things worse than they really are, like let's say on an emotional level, a different pain. You broke up with your boyfriend or something. You think it's the end of the world, and you're not coming out of your house for 2 months, but then someone else doesn't catastrophize the situation, and they're up and about a week later and doing things and getting back into life. There's things about how you're interpreting your situation that can impact your pain. So in this kind of study, it's just reinforcing that if you can help people not catastrophize and educate them and in things they can do for themselves, then they usually have a better outcome. And that was pretty much what I just said. So I made this little upside down pyramid. Oh, how appropriate. If you probably can't see it, but it's called I call it the anti-pain lifestyle. It's just a perspective. I'm not trying to necessarily brand a particular way of doing things. I'm really trying to give people perspective, make people think about things. And this whole idea of the anti-pain lifestyle is very rational, very common sense. You would start with a lower risk, moving to a higher risk if necessary. You would have education that goes along the left side throughout the entire process. And the top part is obviously optimizing your lifestyle, nutrition. You all are wonderful here here. And moving and keeping the range of motion and keeping some strength and also getting some assistance from other people to help you understand your body better. The ones on the bottom 3 rungs there, that's where you actually, in this medical system, make money. So the predominance has been where gravity is taken to where the money, unfortunately, that's what sustains businesses. The top 2, other than, those are usually lower cost treatments. Still businesses are run with that as well. But unfortunately, just like in the educational system, there's some things that are, and when you think of children in the educational system, there's issues there too. But any time you have money dictating where the flow goes, and we're not doing necessarily what's really needed and necessary for society, then things get off balance. So this is a framework I think is good to have in the back of your mind. It doesn't mean they have to be in this order. Some people might have a really strange burning pain kind of disorder called CRPS, complex regional pain syndrome. I usually talk in my longer talk about. But some of those might do better with not the opioids and go to like a spinal cord stimulator, but I still find that there are a lot of other things you can do before you go there. But that is actually a very difficult thing to treat. So the anti-pain lifestyle is just hydrating and your exercise, your basic self-care. Never underestimate self-care. When you're in pain, you actually prove to yourself that you need to do self-care even more than the average person. That's my opinion. I think the more we find that we have health problems, the more we realize, oh, we maybe should do things a little bit better than we've been doing. Not that it's always your fault, it's just it's even more important that you do self-care. So my hope for you is that at least my message comes across to you that as a patient in this medical system at this time, I can't change it overnight. If it was that easy, it would be done already. But that you use the medical system as a bridge, and that you use the education you receive to help guide you over that bridge, and use the bridge is the medical field. So the bridge is you just use temporarily or occasionally, but you're still moving on your own. The last thing I want you to do is actually take that passive role, jump on the train for the medical system, create incredible debt. Not that that's the first thing you're thinking when you're in pain, but when you think about it, it's an extreme expense for you and individually and as a society, and it really doesn't help you help yourself. So I want everyone to know that there's something you can do for yourself. There's something you can do to take care of yourself, and trying to find that information is the journey and the hard part. So this is just a recap of pretty much all those things. Pain can be a gift. We need better understanding. MRIs don't tell the whole story. We need to better diagnose, treat the root cause. And people with pain are not crazy. They just need your help. Opioids just mask the pain alarm. Pain is big business, and don't be passive. Ask questions. And second opinions are definitely acceptable for elective cases. If you're bleeding out, going to the ER, you're probably not going to question anything. You just take care of me, and it's very clear. But in pain, it's a different situation. And we need to collaborate, and we need better education so we can decrease pain and increase function. And I'm so grateful that you let me come here to actually help educate, or at least open people's eyes to the things we need to do better. And I think that was it.
If you have questions, I'd like for you to enter the mic here.
Oh, I forgot to mention, If you got those little piece of paper, I'm going to raffle off a free signed book. I already signed it. My husband, Corey Jackson, back there, he'll come and pick them up if you want to raise your hand, and I'll raffle it off here while we're doing questions or after questions. And in my book, we have a whole bunch of books back there. My husband has a little card reader on I don't actually keep your information. It slides, and I think it's a chip card thing. Anyway, it's $20 for the book. I'll sign it for you personally once we're done, and you can go pay for it through him. So now I can't figure out who's asking a question and who's handing a paper. Wave if you have a question.
Any questions?
Don't be shy. If I don't know the answer, I'll just tell you. I don't know the answer. Yes. Are you asking a question?
Question.
Yay.
Nothing very difficult. I just couldn't remember
No.
what you said the CRPS standard for.
Oh, complex regional pain syndrome.
Complex
Regional pain syndrome.
syndrome.
And that was formerly known as RSD, reflex sympathetic dystrophy. So it's more of a burning pain. It's probably one of the worst pains that you hear about people talking about. Worse than labor pain, too.
If you have more than one type of pain, where do you start? Which one do you start with?
Good question. Well, the funny thing, well, not funny, but if there is multiple pains, sometimes if there's one that's very prominent, it may be so distracting that you don't notice you have other pains. You might find that if you address the most prominent one, then the other ones you can notice more. It's just kind of the way the brain can change things for you. And let me also be very transparent. So I am currently working as an anesthesiologist, currently, for now, 4 days a week. I'd like to go to 3 days a week soon. But I'm not working in a pain clinic. I do feel like I'm helping people with pain because I think education is so valuable and it's underappreciated, it's under reimbursed, so therefore it's under-delivered. And so I do feel this strong mission that I need to get out there and join forces. And if you've never seen the video called The Hardest Pill to Swallow by Tracy Jackson, I actually reached out to her, and we're probably going to be doing a few things together and creating. She has a thing that she wants to start next year called Relief Retreats. It's not started or anything, but it's actually for creating scholarships for people with chronic pain, where we're going to raise money to help give scholarships to people who have really difficult chronic pain and take them to these relief retreats to try to help them, because it's so difficult to find an integrative, collective type of clinic for people unless you are workers' compensation or you're rich. So this needs to be more prevalent so that people aren't so frustrated with running around to 10 different people and having a hard time. So to answer your question as far as where to go, as far as what kind of thing to treat, it really depends on what it is. And I always say for any patient, it depends. Because I'm not just going to go off one thing. I want to know a little bit more of the story. And obviously we wouldn't do that here, but it depends. Yeah. Any other questions? Yes.
Seems like there's an epidemic of fibromyalgia,
Yes.
and with pains just starting in the central nervous system, I guess. And so where would you begin with something like that?
fibromyalgia?
Yeah, which seems different than just
Yes.
the pain from hurting yourself.
Right. So it's one of those that just kind of comes on insidiously.
Yeah.
You don't really have a particular incident. And it's one of those constellation of symptoms diagnosis. So it really doesn't give you the answer why. It's just, and I'm saying that fibromyalgia it's a diagnosis created by humans trying to put a definition or a diagnosis for these symptoms. So as far as how to address it, the best thing is an integrated approach, because maybe there are multiple forces that cause the same kind of similar constellation of symptoms. However, I have a couple of very close colleagues that are in pain practice, deal with a high volume of patients, and he's convinced that one of the big components he's finding is that a lot of those patients that have the fibromyalgia don't have good sleeping patterns. And I didn't have it in this particular lecture, But there are plenty of studies to show, and you've been on call all night at some point in your past. And if anyone's ever done an all-nighter and had some problems with feeling pain, you just feel horrible. And or maybe your temperature regulation is off, like everything's just off. So the nervous system is definitely involved, and there's all these trigger points. You can measure all these things and say, okay, you fit the fibromyalgia diagnosis. Well, the question, what do you do with that? So to me, nutrition is, I think there's a lot of things that are, and you guys know tons more than I do, but there's no doubt that what's in our ecosystem, our entire system, there's things that are invisible. I think some of the things that we're going to find out later are the things that are invisible to our naked eye, and we're going to realize that they're having an effect on us, maybe a cumulative effect, maybe on the nervous. These are just theories and ideas, but lack of sleep, our high stress environments, our current today activity seems kind of normal to us, but it's just because our brain is neuroplastic. It gets, actually I thought I had a slide on that today, but neuroplasticity just means your body is always evolving and changing based on the input it gets. So you've heard of PTSD. That's an extraordinarily ramped up nervous system. Someone's been in Iraq and had seen something horrible, and that system is just on high alert, and you can't get it down. But I think there's various gradations of stress on the nervous system that have different manifestations in the body. So not everyone's going to have the exact replica. Even if they had a fibromyalgia, they may have a different, and even if they're really the same thing for each person, we're diagnosing them as that. It may not, we may change the diagnosis, just like RSD was changed to CRPS. I mean, these are just terms that we're trying to just get a sense of what's going on with the human body. So that's why patients can teach us a lot. Yeah.
Thank you.
Yeah.
There's actually a proposal to change the name from
I haven't even heard this yet.
fibromyalgia to dysregulation syndrome.
Yes.
Because everything's dysregulated.
Yes.
Sleep, gut,
Absolutely.
brain,
Yes.
everything.
Yes. That's a good question,
They don't want to know. They
Yeah.
don't really want to know.
though. Yeah. Yeah. I personally, if I ever had a place, I'd probably go cash only, just because I just don't want to have to deal with having to describe the value of education, describe the value of, of what we do, or having to substantiate things. If you just care for people and good value and make it affordable, that would be the ideal thing, but it's hard.
Yeah.
you have a question?
This young lady here was asking about
Yes.
whether or not an endocrinologist would be someone that you'd want to see for pain.
It depends.
So I would just answer that
have
yes,
to
it's part of if your hormones are dysregulated, your thyroid's dysregulated, it could have a bearing on the pain. And so I think that's why just the main point that I pick up from you is that pain is just not a physical symptom. It's really a signal from the body that something ain't right.
Right.
And if you go to the mechanic with your oil light on and he gives you a piece of black tape and says, just cover this up, you'll feel better, call me when the engine quits, that is not pain management.
No, and it's not good pain care, in my personal opinion. And I actually like to remind, it's actually in my other talk, is just we try to simplify the body so much into the car analogy, and I do it too sometimes, but I have to stop and remind myself that we are so much more incredibly brilliant, our bodies, if we take care of it. In most cases, it does just great. It's just we keep pushing the limits in various ways. And the difference between the car and your body is that it's not going to heal itself. And our bodies were born to heal themselves. If we had to think about every single thing that we need to do to keep our body running, we'd all be dead. I mean, it's the reality that there's billions of processes going on in your body that you're not consciously directing them. You're not orchestrating them. So the more you keep your body in homeostasis and do the good things, and it usually serves the body well. So.
Any other questions?
I just wondered if you'd heard of the so-called natural plant-based item called kratom for pain.
No, how do you spell that?
Kratom.
I don't know,
Somebody
have you?
recently, and another person in my family that has
I've never heard of
Probably
it.
worse back and leg pain than I do.
Mhm.
And I'm for not taking drugs. It's just, I've learned.
Sure, if you don't have to.
And thankfully, I didn't even take chemo, but I think the big problem for my sleep is,
Yeah.
back and leg pain.
Yeah.
But I've heard of that, and I've heard that it could have side effects. I just wondered if you'd heard of it or knew anything about it.
No, I've never heard of it. I'd like to look it up, but I would say true nerve pain, I think, is one of the hardest things in the pain world. It's hard to deal with. It's even no matter how good you try to take care of yourself, sometimes some of that, like chemotherapy-induced nerve pains and other nerve pains, can be horrible for people.
Just as a general comment, inflammation is oftentimes the fundamental factor at work where something has been injured or toxic or out of balance, and the body's actually trying to send a signal to heal, and that's what inflammation is. It's really oxidation as a signal enlisting the healing system, which is inflammation, to go to the area that's injured. But when you have multiple pain sites, the inflammatory system gets confused and everything starts becoming dysregulated. And so, but the idea of inflammation, oxidation is really a good fundamental place to start, because a lot of the natural healing remedies are really phytonutrients that are very powerful antioxidants. Or vitamin C can help with pain. Vitamin D reduces inflammation. And so it's not that you want to take those as individual magic bullets,
Right.
but it's being able to orchestrate all the various nutritional factors. Exercise. The fibromyalgia thing that
Yeah.
Dr. Cady was talking about, there was actually a study where they took medical students, the ultimate lab rat,
Yes.
and they purposely deprived them of sleep. But and the way they did it is they put little electrodes on their eyelids, and when they would fall asleep and start to dream, they would have some kind of a noxious sound that would wake them enough to where they wouldn't dream. They would not get the rapid eye movement. And after 2 or 3 nights of this in a row, they would have the classic fibromyalgia symptoms, except the medical students that were runners or exercisers. That seemed to have some kind of a immunization against the whatever was happening to the disruption of their normal body homeostasis. So things like exercise, good quality food, sleep, healthy relationships, movement, posture, all these things that hydration, if you don't hydrate yourself, your body will make more histamine. Histamine is a pro-pain. It's a neurotransmitter that can cause more pain. So just by hydrating more adequately, you can help reduce your pain. So all these things together create a symphony of protection against the effects of modern lifestyle, which tend to dysregulate us quite a bit.
I like the word symphony. That's
Yeah, that's what you have to do.
No, it's very good. And
Orchestration.
and there is a study too with showing people that did 3 days of biking, 20, 30 minutes, versus someone that did nothing, and they used like a cold presser technique to induce pain. And the toleration of that was much better with the people that did a few days of exercise. You don't have to be perfect, but you have to institute activity.
The interrupted sleep pattern, that can cause problems, or does the problem cause the sleep pattern?
The pain, you mean the pain causing?
It wakes you
Well,
up. It
it's a
wakes you
vicious
up
cycle.
multiple times.
Right. It's a vicious cycle. So you have to really look at the entire picture of your entire, they call it biopsychosocial environment. Just means the biological components, the things that could be causing, whether it's musculoskeletal, other things. And then you have to look at maybe the kind of stress that you're under, the environment that you live in, just to figure out what is it that you can maybe try to get the pain a little bit better so you can get sleep. But if you wake up and never get the REM sleep and the deep sleep, then you're gonna, it is a vicious cycle. Trying to figure out which point you can help it the most, that's where the trick is, and that's what you have to work with a professional and figure that out for yourself. It's not easy.
I'm using vibration.
Oh,
I've got a
does
little
that help?
vibrator in my bed. Yeah, it does, puts you back to sleep. But I wake
It's-
up from midnight on, every hour, every 30 minutes.
And there could be other reasons for that. I don't know.
I'm blaming it on the pain, but I don't know that.
Yeah.
Because when I relocate, turn the vibrator on,
Yep.
sleep instantly.
Right. Well, the question is if they did, and not that I'm a big injection person, but sometimes if they're able to, if it was a little spot and they numb the spot and there's no pain, and then you go ahead and go to sleep and you still wake up and you didn't have pain, that would tell me that's probably not the pain doing that. It might be something else you need to root around for. So there's different ways you can use the medical system for that.
They have multiple spots.
Right, you could.
From feet up to about here.
Right.
So
So you're unique, and the person that helps you is going to have to look at your uniqueness and spend time with you to try to figure out a few plans. And you do have to be an investigator. You can't just let us do it because you're living in that body.
I've been looking at it.
Right. No, but you're here. So that
It's
says
still in progress.
it's what?
It's still in progress.
Good. And don't quit. I always tell people, keep the hope in what you're doing, because there are people out there trying to really help, and hopefully one day you'll find the right answer. And sometimes time is good too. Time can, there can be healing that can go on, or things can change. So, any other questions?
Well, thank you very much, Dr. Cady.
Yeah,
Wonderful
it's a
lecture.
pleasure.
It's great to have you here.
Yeah, thank you. I appreciate it. Thanks.